This educational video is intended to provide individuals working or about to work in an inpatient mental health hospital environment with a basic understanding of inpatient treatment programs.
It takes collaboration across a community to build better skills for better lives.
Whether you're here to start work as a mental health technician, a seasoned professional transitioning into a mental health specialty, onboarding in dietary, admission and referral, or EOC departments, or joining in a behind-the-scenes role with administration, employment in a behavioral health hospital means being part of its treatment program. Reaching your fullest potential, whatever your job title, requires a basic understanding of mental health care, the treatment program you are about to become a part of. In addition to awareness of your own and other important roles in delivering the treatment, our inpatient program is intended to provide. Explanation and treatment of behavioral health problems have evolved dramatically across time. Therefore, a good understanding of modern inpatient psychiatric care begins with awareness of key historical concepts. Because we can't know where we're going until we understand where we've been.
Essential mental health history in America can be divided into three major eras. We define era as a period of time that is different from other periods, due to specific events, characteristics, or cultural norms. The eras of mental health care are distinct periods of time when a particular set of beliefs, ideas, or practices surrounding mental illness were both prominent and fundamentally different than those of the periods before or after them. Specifically, these eras are defined by radical differences in prevailing beliefs about the terminology used to describe the mentally ill, the underlying causes of mental illness, the solution, or what needs to be changed, in order for symptoms to resolve, the methods of treatment necessary to bring about that solution, and the expected roles of the patient, caregivers, communities, and governments in the treatment process. There are three major eras critically relevant for the understanding of modern inpatient mental health care. The pre-institutional era, from the late 1700s to the mid-1800s, the era of institutionalization, from the mid-1800s through the 1950s, and the deinstitutionalization era, from the late 1950s to the modern day. Let's take a closer look at the differing concepts representative of each era. We begin in colonial America of the early 1700s. In colonial times, mental illness was primarily explained as supernatural alteration. That is, the mentally ill were usually believed to be either possessed by demons or adversely affected by the forces of nature. In particular, the effects of the moon were believed a frequent cause for madness, hence the common use of the term lunatics to describe them. Care of mentally ill persons in colonial times was a primary responsibility of families. As then it was a shameful affair, families often confined their affected kin to cellars, attics, and outhouses. Beyond the interventions any average family could provide, professional treatment options were limited primarily to exorcism, and were delivered by spiritual leaders. Less commonly, some wealthier families might visit their local barber for professional bloodletting. Mentally ill persons without family often roamed from town to town, where the communities, eventually via their county government, were obliged to act as surrogate family for the unmanageable, or at least those locals weren't able to warn off. With few options more than what a family could offer, those under such surrogate care were most often treated by confinement to jails leashing to whipping posts, or chaining to walls. As early communities grew larger, so too did their need for more regulated systems of caring for the increasing monolithic, roaming masses of the indigent and insane. And by the turn of the century, the catalyst for the first major change in beliefs and practices surrounding mental illness in America arrived from Europe. In his Treatise on Mental Alienation or Mania, published in 1801, French doctor Philippe Pinel disseminated a provocative new idea, that mental illness might not be solely due to external forces, but instead could be the result of a dysfunctional component within the individual themselves.
One of the major principles of psychological management of the insane is to break their will in a skillfully timed manner, without causing wounds or imposing hard labor. Rather, a formidable show of terror should convince them they are not free to pursue their impetuous willfulness, and that their only choice is to submit.
Dr. Felipe Pinel.
The first American to promote this new idea that the cause of lunacy is internal, or moral, was founding father and signer of the Declaration of Independence, Dr. Benjamin Rush. And through the early 1800s, treatment options expanded from just spiritual or restrictive approaches to include this new moral option. Moral treatment primarily involved removing the afflicted from their homes to be placed in a surrogate family environment, where they would live under the authority of caretakers whose rules of living would emphasize religious morals, benevolence, and clean living. Such models for moral treatment signified the beginning of yet another major change in American mental health culture. That primary responsibility to provide care and treatment for the mentally ill no longer rested solely on the family or a family surrogate, when families were no longer expected to be the sole provisioners. Funding and operation of moral treatment became a responsibility of the community, via county government. So, echoing the English Poor Law of 1601, counties began to levy taxes, funding the construction of poor houses, aka poor farms, and to pay the appointed overseers of the poor needed to run them. Driven to reduce this new financial burden, the counties then began to offer a small monthly payment to citizens willing instead to take an indigent into their home. These small monthly fees amounted to less than the county's cost to care for the person full-time. The free income, along with the free labor provided by an indigent, all added up to serious benefits for farms and businesses alike. Eventually, this even led a market to develop wherein many poor farms began holding regular auctions, in which they would send their county wards off to work for the lowest bidder. At a time when lack of support from either family or community meant likely starvation, or some other gruesome end, for the mentally ill, and other individuals who could not independently provide for themselves, the relative benefit for these individuals was also significant. Therefore, history still looks back on the poor farm system not as one of slavery or indentured servitude, but rather as an early form of social welfare system. But certainly, it is still wise for us, and future generations, to always be mindful of the early 19th century poor farm system's functional role as a platform for the farming out of the poor. By the early 1800s of antebellum America, the medical community slowly began to adopt the idea of mental illness as a potentially medical problem. Soon, private asylums would be built as the first hospitals, dedicated solely to admission of patients with mental health complaints, beginning with Boston's McLean Hospital in 1818, first known as the Asylum for the Insane, followed by the Bloomingdale Asylum in New York and Pennsylvania General in 1841. And when one builds a hospital, he must have a doctor to treat the patients. Just as other advancements in medical knowledge and training drove the transition from barbers to doctors, so too the role of expert in treating mental illness gradually migrated from the spiritual leaders to physicians. It was the alienist's job to study, understand, care for, and assist asylum patients in overcoming their mental alienation. The asylum's first superintendent, Rufus Wyman, M.D., was the first physician appointed to such a post in America. Not until a century later would the alienists be given the much less charismatic title of psychiatrist. Contrary to modern notions that all historical asylums were all terrible places, the earliest psychiatric hospitals were private institutions dependent on financial donations. Tailored to attract the money of wealthy donors, the accommodations could be surprisingly comfortable. For example, some at McLean Asylum, renamed in 1826 after its largest donor John McLean, even enjoyed living in private cottages with their hospital attendants. Cottages their families paid for, and would later deed to the hospital, as gratitude for their relatives' exceptional care. But where a small number of fortunate individuals could receive care in these private asylums, the majority of the insane living in the pre-institutional era remained in the hands of the county jails and poor farms, where they found their conditions of living much less appealing.
The mid-19th century marks the rise of a uniquely different mental health era. The first private asylums, built in the early 1800s, may have signified the medical community's growing acceptance of mental illness as a medical problem, but what they produced was an even more significant precedent, which laid a foundation for the era to come. At a time when effective medical treatment did not yet exist, pre-Civil War hospitals primarily served as a place for sheltering and caring for the poor and familyless who were sick. Essentially a place for them to die. However, these early private asylums built for the mentally ill established an entirely different precedent, that inpatient care of mental illness in a hospital offered something more than could be provided by poor farms, or even a family's care. And so it was, that alongside the bricks used to build them, an unprecedented new societal belief was also mortared into place, one that would prove long-lasting, the tenet, that all with mental illness benefit from care in a hospital. The changes that followed were driven by a new breed of social reformers, advocating against the horrible living conditions of so many of society's unwanted. These pioneers of mental health advocacy and activism, primarily Civil War women, challenged the prevailing views that insanity was the result of moral defects, or that it could be expected to reform through prayer, discipline, or willpower. And no single activist would prove more influential than the one, Dorothea Dix.
A teacher-turned-Civil War nurse who led the reform efforts of the 1840s, Dorothea is often credited with the birth of America's first generation of public mental asylums. With a zealous lobbying campaign to Congress and state legislatures across the country, she gave voice to the demands for improved living conditions for the insane. We can still experience the fervency of Dorothea's words in the speeches she left behind.
More than 9,000 idiots, epileptics, and insane in these United States, destitute of appropriate care and protection, bound with galling chains, bowed beneath fetters and heavy iron balls, attached to drag chains, lacerated with ropes, scourged with rods, and terrified beneath storms of profaned exhortations and cruel blows, now subject to jibes and scorn and torturing tricks, now abandoned to the most loathsome necessities.
And upon close examination of her arguments, distilled the transformative logic in the sequence of novel ideas that would define the next era in mental health care. These are the concepts that built the institutions. Mental illness is fundamentally incurable. All mental illness is suffering, and all would benefit from inpatient care. All mentally ill people are inherently unable to make rational decisions. Society has a moral obligation to relieve the mentally ill by providing for them a life of dignity and humane care. Eventually, as this distinct set of beliefs grew prevalent, society would ultimately arrive at the illogical conclusion and defining concept of the institutional era that commitment to an institution is a requirement for the proper care and treatment of all people who have mental illness.
Dorothea's persuasive campaign was quickly followed by the construction of large state-funded hospitals across the country, who quickly found demand for their beds. Hence, the notion of the long-term institution was born, built, and populated.
In this process, the expected role of government in mental health care expanded to include state government for the first time. And by their funding of these large public asylums, the precedent was set. The state's role was now to both provide and indefinitely fund inpatient treatment for all societies mentally ill. In all times previous, it was the family, and to a limited extent, their county, who owned primary responsibility of both care and financial support of the mentally ill. However, invention of the public asylum in 1840 society effectively shifted ownership of this responsibility to the state, leaving families and their counties with seemingly one last responsibility: to deliver the afflicted safely into the waiting arms of the state asylum. Though seemingly few, there were voices even then who spoke out in wary dissent to pre-Monash society about its newly emerging ideologies. Dorothea's persuasive campaign was quickly followed by the construction of large state-funded hospitals across the country, who quickly found demand for their beds. Hence, the notion of the long-term institution was born, built, and populated. In this process, the expected role of government in mental health care expanded to include state government for the first time. And by their funding of these large public asylums, the precedent was set. The state's role was now to both provide and indefinitely fund inpatient treatment for all societies mentally ill. In all times previous, it was the family, and to a limited extent, their county, who owned primary responsibility of both care and financial support of the mentally ill. However, invention of the public asylum in 1840 society effectively shifted ownership of this responsibility to the state, leaving families and their counties with seemingly one last responsibility: to deliver the afflicted safely into the waiting arms of the state asylum. Though seemingly few, there were voices even then who spoke out in wary dissent to pre-Monash society about its newly emerging ideologies.
As it is with individuals, so it is with communities. And society, moved by pity for some special form of suffering, hastens to build up establishments which sometimes increase the very evil which it wishes to lessen. Our people have rather a passion for public institutions, and when their attention is attracted to any suffering class, they make haste to organize one for its benefit. But instead of first carefully inquiring whether an institution is absolutely necessary, that is, whether there is no more natural and effectual manner of relieving the class, and afterwards taking care that no vicious principle be incorporated into the establishment, they hastily build a great showy building, and father within its walls a crowd of persons of like-conditioned infirmity, and organize as community where everything goes by clockwork and steam.